Enameloplasty. This is a procedure that every dentist should have in their armamentarium because it can markedly simplify cases. The indications for enameloplasty: the first is to go in and improve anterior aesthetics, and typically orthodontists will do this when they finalize the case just to improve the aesthetics. The second indication is to increase the occlusal space in the posterior area to create space to restore. The third indication is to minimize the black triangle between maxillary central incisors when orthodontic treatment is being completed. Here we have Cathy, a 78-year-old female. The suggested treatment plan was to extract the remaining upper teeth because the teeth are unesthetic and the patient cannot afford crowns. The actual treatment was by selective grinding to do enameloplasty and give her a maxillary partial. I think it's very obvious on the upper slide how unesthetic these teeth are because of the extrusion, especially of that central and lateral. And as I said earlier, by selective grinding, we went in there and reduced that, and following that, look at the impact on the lower that this had on the aesthetics. But when the patient smiles, look at what a marked impact this had. And as we said earlier, this patient could have a maxillary partial and save her anterior teeth, and she was certainly pleased with that outcome. The next patient is Janie, a 71-year-old female, and look at the extreme extrusion of the first and second molar. Because of this, a typical treatment plan would be to go ahead and remove those teeth, do a sinus lift or sinus surgery to add bone, and place implants. But what we elected to do, even though this patient did have a 10mm pocket on the mesial, to go ahead and do a regenerative procedure there following the enameloplasty. We mentioned a 10mm pocket, and I'm sure you're thinking, well, that tooth has a poor prognosis. But if we go to the Miller-McIntyre Periodontal Prognostic Index, you can see that the patient has an excellent prognosis given the fact that treatment will be done. And we can reduce the Miller-McIntyre score down to a 3, so the patient has a 96% chance of keeping that tooth for 15 years, although there will be perhaps a residual periodontal defect on the mesial of that first molar. There are 2 videos, lectures on the Miller-McIntyre Prognostic Index available on the web textbook, and you can view these by clicking on these annotations. So let's get back to Janie. Here we see initially where we started, and the first time that we did enameloplasty, we did get into dentin, but we didn't get as much reduction as we wanted. So this is where we started, 5mm, and look at the second molar, not room to do anything back there. But after the second enameloplasty, you will see that there's a 9mm space here. We can see how the distal of that marginal ridge on the second molar was modified so there would not be a protrusive interference in the posterior area, and you can see where we did the regenerative surgery on the mesial of the first molar. If you're going to do this, these are the considerations that you need to be aware of. First, do not anesthetize the patient. Well, that's obvious. If you're going to do enameloplasty, and in this particular case you're going to get into dentin in the posterior area, there's a problem with sensitivity. But on these older patients, do not anesthetize, and let the patient know that you will stop immediately at the first sign of sensitivity. It's very interesting how much dentin you can remove on these older patients before they begin to be sensitive. And often a significant amount of dentin can be removed, as I said earlier, before the patient becomes sensitive. And as we did in the last case, if more reduction is necessary, wait a few months and do further reduction. Treating the black triangle. This is something that is very much concern to patients as well as dentists. This is a patient in the middle of orthodontic treatment, and you can see the roots have not been parallel, and we can see the black triangle present. So, when the roots are paralleled, most of that black triangle goes away, but we still have a significant amount which may be unacceptable to the patient. And the final thing for the enameloplasty is to go in there and do a little enameloplasty on the mesials of those two central incisors, close the space, and when you do that, the papilla will come down about 1 millimeter and the contact point will move apically about 1 millimeter, and you will have a very significant impact with your enameloplasty. So this is what we need to have done, and that is about 0.5 millimeter on either side of enamel needs to be removed. But let's look at a case by Dr. Vince Kokich, the late Dr. Kokich. If those teeth are going to be aligned, they are going to move distally, which means the gingiva in the papilla area is going to move apically, as you will see occurred here. Certainly an unaesthetic and unacceptable for the patient. So what Dr. Kokich did, you see where he went in and did the enameloplasty that we talked about. Note how the incisal edges will be slightly modified, and this is the way the case will look in a matter of days after that. So think in terms of what enameloplasty would bring to your practice. First of all, it's a simple way of improving anterior aesthetics. Secondly, it is a means of gaining space in the posterior area to simplify treatment plans. And third, it can be used post-orthodontically to reduce the size of the black triangle. Use this procedure and enjoy.